topics. One will be on tension pneumothorax, care of intercostal veins, and about HFNC and ROX index. Now, all questions have been asked in theory, either in the main exam or in the formative assessment test. And also, it is important to know about these topics from a practical perspective also, because tension pneumothorax from a practical perspective can be asked in a radiology section, or they may keep intercostal drains in your equipments and ask you to elaborate about it, and they may ask you about management of drains also. And HFNC circuits itself may be kept in the equipment station, and they may ask you related trials. So you need to know about it. And if at all they go into HFNC in your practicals, they will definitely ask you about ROX index. So that's why we thought that these topics should be covered, and we will proceed now. So the first topic I'll be discussing is on tension pneumothorax. So coming to the introduction, now pneumothorax is collapse of lung when air accumulates between the parietal and visceral pleura within the chest. So air is outside the lung, but inside the thoracic cavity. So this places pressure on the lung, leading to collapse and shift of the surrounding structures. So how can you classify pneumothorax? It's pretty straightforward. One is simple or a tension. The only difference between both of them is in simple, there will not be any shift of mediastinal structures, whereas in a tension, there will be shift of mediastinal structures. So this is the important difference that needs to be kept in mind. So coming to the etiology, it can be classified as traumatic and atraumatic. And the last is miscellaneous. So under traumatic, you have following penetrating or blunt trauma that can be because of rib fractures, or iatrogenic, following CVC insertion through an IJV, internal jugular vein or a subclavian vein, following lung biopsy, percutaneous tracheostomy, pacemaker insertion, bronchoscopy, CPR, or intercostal nerve blocks. So in any of these situations, pneumothorax can occur. Whereas atraumatic can be primary, where the cause is not known. So the risk factors for primary pneumothorax can be because of cigarette smoking, cannabis, or cocaine. Or there can be genetic predisposition like alpha-1 antitrypsin deficiency or Marfan syndrome. Or due to increased Valsalva maneuver as seen in deep diving or military flying, whereby there are large amount of pressure changes. And secondary atraumatic causes usually are seen in patients with an underlying lung disease like COPD, lung malignancy, necrotizing lung infections like pneumocystis, TB, bacterial, under bacterial streptococcal infections, staphylococcal, Klebsiella, or Pseudomonas. So any of these kind of necrotizing lung infections can predispose to pneumothorax. And under miscellaneous causes, it can be because of anorexia, catamenial, or exercise. So this is one of the best way of eliciting the etiologies in relation to pneumothorax. Now, the important thing to note is all the causes that I've mentioned above can lead to a tension pneumothorax. So coming to the pathogenesis. So under normal circumstances, the pleural cavity pressure or the intrapleural pressure is negative as compared to the lung pressure and the atmospheric pressure. So this is something that most of us would definitely know about. So there is a tendency of the coil to recoil inward and the chest wall to recoil outward. So the pulling on opposite sides generates a negative pressure. And that negative pressure or the pressure gradient that is developed prevents the lung from collapsing. So as you can see here there is a negative pressure or a pressure gradient that is generated because of the inward pulling of the lung and the outward movement of the chest wall. This mechanism is lost in pneumothorax. So during a pneumothorax, a communication develops between the pleural space and the lung. So this results in air movement from the lung into the pleural space. Because of this, there is nullification of the pressure gradient that is usually present, and that leads to a progressive rise in the intrapleural pressure. So as air accumulates in the pleural cavity through the disrupted pleura, but it is unable to exit it like a one-way valve, that leads to increase in intrathoracic pressure in the affected side. So the increase in intrathoracic pressure in the affected side is going to create a lot of problems. The first is it is going to compress that lung on that side, decreasing its volume available for ventilation. So that causes a collapse, and the affected lung is unable to function at its normal capacity. So because of this problem, there is a decrease in gas exchange, which leads to hypoxia. So because hypoxia starts to set in, it causes stimulation of your hypoxic pulmonary vasoconstriction, which in turn leads to an increase in your pulmonary vascular resistance. So that further worsens hypoxia, and because there is an increase in pulmonary vascular resistance, it starts to affect your cardiac output. On the other side, there is also compression of your mediastinum. So it pushes it to the contralateral side, compressing the heart and the great vessels. So because of that, there is a decrease in your preload and your cardiac filling pressures, which leads to a decrease in cardiac output. So ultimately, if hypoxia and the cardiac output further get impaired, it is ultimately going to lead to cardiac arrest if it is not treated in a timely manner. All right. So as you can see, pneumothorax causes two problems. One is it causes collapse of the lung. It impairs the gas exchange. Another side, it causes compression of your mediastinum, thereby compressing your heart and the great vessels, impairing the venous return, decreasing the LV pressure, and ultimately reducing the cardiac output. So on one hand, because of hypoxia, and on the other hand, because of the decrease in cardiac output, it can lead to cardiac arrest. So clinical evaluation, from an history perspective, usually they will present with sudden onset breathlessness ranging from mild to severe. That is, if they are conscious. Usually they will may complain of unilateral pleuritic chest pain, and it is always important to look for risk factors and genetic predisposition in patients who are present with pneumothorax but with no other preceding or any predisposing history like trauma or any iatrogenic factors. In those subset of patients, always you need to look for these risk factors that I had mentioned and the genetic predisposition like alpha-1 antitrypsin deficiency or Marfan syndrome. So in physical examination, in mild cases, usually nothing much is elicited, but in severe or like in tension, there can be enlarged hemithorax on the affected side. There can be decreased breath sounds, absent tactile or vocal fremitus, and hyperresonance on percussion. If hemodynamic compromise occurs in the background of a pneumothorax, it is supposed to be a very, very ominous sign. So diagnosis based on bedside investigations like ABG, during the initial phase, there will be hypoxia and respiratory alkalosis due to the well-functioning contralateral lung. And during the subsequent courses where the patient starts to go into fatigue, respiratory acidosis can set in. On the other hand, metabolic acidosis can be there because of the diminished cardiac output, which can lead to hyperlactatemia. ECG changes are usually non-specific. The most commonly seen is sinus tachycardia. If there is previous evidence of chronic obstructive lung disease, then there can be a right bundle branch block with the possibility of a RB strain being also present. So chest X-ray is usually not done in unstable cases due to logistic issues because the time taken for a portable X-ray to reach will be a very concerning issue in a patient who presents with the tension and has hemodynamic compromise. So in those kind of situations, ultrasound plays a big role. So the effect of position in relation to the X-ray. So the R moves to the least dependent portion of the lung, and thus the radiographic appearance of pneumothorax depends on the patient's position. In usually the supine position, that is mechanically ventilated patients, the pleural gas accumulates anteriorly in a subpulmonic fashion. So that usually leads to the typical deep sulcus sign. So what that is it basically the gas outlines over the costophrenic sulcus. So it gives an amplified view of the costophrenic sulcus. So in mechanically ventilated supine patients, other findings that can also be found are subcutaneous emphysema can be seen, especially if it is traumatic or iatrogenic, and tracheal deviation to the opposite side can be there. And in patients with the pneumomediastinum, there is something called the continuous diaphragm sign. All right, so there are pictures in the subsequent slides, but these are the things you need to keep in mind. So with respect to the chest X-ray, you need to always assess for the possibility of a deep sulcus sign. You need to assess for tracheal deviation. Then you can also assess for possibility of a subcutaneous emphysema. And if pneumomediastinum is also present, then there can be a continuous diaphragm sign being evident. So here, as I said, the air accumulates in the costophrenic sulcus, as we can see here, making it look more amplified. So here it is very much visible, and this is called the deep sulcus sign. So here you can see the diaphragm has a continuous structure. All right. So this is supposed to be the possibility of a presence of a pneumomediastinum. Here is a more well-defined image. So this is the continuous diaphragm sign. So the next question, which is usually asked, especially in the radiology station, is assessment of the size of a pneumothorax. So there are various techniques of assessment, one of which should be at least being noted to you. So the British Thoracic Society guidelines, they have one of the techniques of assessment whereby you assess the distance from the chest wall till the visceral pleural line at the level of the hilum. So if this distance is less than 2, it is a small, and if it is more than 2, it is large. So it usually roughly correlates with the pneumothorax occupying 50% of the thoracic cavity. So this is one of the techniques of assessment, but this is very, very vague. It gives you just a rough estimate. Another technique that can be used is assessment of 3 points. One is the vertical distance from the maximum point on the parietal pleura to the visceral pleura. That is taken as A. Then at the hilar level is B, and at the lowest level is taken as C, the distance between the parietal and the visceral pleura. So then the summation of these three are taken and then divided by 3. So that gives you the percentage of the pneumothorax. So that is also another way of assessment. So I'll just repeat it once more. A is the vertical height from the topmost part of the lung, from the parietal to the visceral. B is at the level of the highlight, and C is at the lowest point. So the difference, sorry, the summation of all these three are taken and divided by 3. So that will give you a number. So that number will roughly correlate with the percentage of size of the pneumothorax. So one of the main modalities that can be used for diagnosis is lung ultrasound or pleural ultrasonography. So the important things to elicit are the absence of lung slide, absent B lines, absent lung pulse, and presence of lung point. If all of these are present, then pneumothorax can be confirmed, and the sensitivity is 94% and the specificity is 100%. All right. So if all these four signs are elicitable, then your specificity goes up markedly up to 100%. CT scan usually not done in cases of tension pneumothorax because of logistic issues. You cannot, when the patient is already that sick, it is very difficult to transport the patient all the way till the CT room, get it done, and then shifting back. You have better modalities that can be done at the bedside for diagnosis. So this is lung point. As you can see, there is one part of the lung where there is no lung sliding, and there is another part where there is lung sliding occurring. So this area where there is a common distinction between the two parts, that is the lung sliding being present and not being present, is called a lung point. So the main rationale for this is when a pneumothorax occurs, it is not like that full gas in the pleura is going to affect all the areas of the lung. There will be some areas of the lung which will be still aerated and some which will be affected by the pneumothorax. So that can be identified by the presence of lung point. So lung point is supposed to be highly specific for a pneumothorax. So then presence of lung sliding. So this is one thing which most of you would know, because presence of lung slide, if it is there and if B lines are also present, then it rules out pneumothorax, because for a pneumothorax to be there, there has to be air within the pleural cavity. So if there is air in the pleural cavity, the underlying lung structures will not be visualized because the air doesn't allow the transmission of the underlying structures. So in that kind of a scenario, if you are able to see B lines or if you are able to even see mild lung sliding being present, then it rules out a pneumothorax. So here you can see the presence of B lines. Most of you do ultrasound. I hope most of you do ultrasound on a regular basis, so you would know about all these findings. So the next parameter is lung pulse. So it refers to the sonographic finding of apparent oscillations of the pleural line occurring secondary to transmitted vibrations from the contracted cardiac activity. Very simple to say. Usually in patients who are paralyzed and not ventilated, if you keep a capnographic waveform, you will be able to see cardiac oscillations. Similarly, if you in a patient who is having a pneumothorax, patients who are having an atelectasis, whereby there is no ventilation of the affected side because of collapse, if you keep the lung ultrasound in M mode, you will be able to visualize the cardiac oscillations. Whereas in a patient with a pneumothorax, that cardiac oscillations will not be visualized. Like as I had mentioned previously, when pleura is accumulated with air, it will not be able to visualize the underlying structures. So the absence of lung pulse indicates a pneumothorax, whereas the presence of a lung pulse may possibly indicate the presence of an atelectasis. So that is an important differential that needs to be kept in mind. So coming to the treatment, as you all know, we always go in a ABC pattern. So airway breathing circulation has to be established. If the patient is hemodynamically unstable, you first go with needle decompression without any delay. So traditionally, they used to say you need to go on the second intercostal space at the mid-clavicular line. So once the tension is released, then you proceed with the chest drain, and it is placed attached to a underwater seal. So the technique of doing it can be via Seldinger or dissection technique. Whereas if the patient is not hemodynamically unstable, then you don't need to really go for a needle decompression. You can directly go for a ICD insertion. So needle decompression, why is it done? It basically helps to convert a tension pneumothorax into a simple pneumothorax. So whether needle decompression is a definitive therapy, no. It is just the initial life-saving maneuver. The definitive one would be to go with the ICD insertion to get all the pleural air out of the lung. So the recent evidence supporting large over-the-needle catheter, the position where it needs to be done is at the fifth intercostal space, slightly anterior to the mid-axillary line. So this needs to be kept in mind. Previously, they used to say at the level of the second intercostal space, mid-axillary. But now they say fifth intercostal space, slightly anterior to the mid-axillary line. So finger decompression. Tension pneumothorax can be managed initially with rapidly applying the finger decompression technique. Due to variable thickness of the chest wall, kinking of the catheter, and other technical or anatomical complications, needle decompression may not be successful. In this case, a needle thoracostomy is an alternative approach. Though it is not routinely done, mainly in trauma patients, it can be considered. Because in other subset of patients, whether being iatrogenic or atraumatic primary or secondary, this technique is not usually done. This is one thing which is being recommended by the ATLS. So coming to the selection of tubes, so majority of patients with stable cases due to a spontaneous or iatrogenic etiology, and 88 to 14 French is usually sufficient. But if the patient has features of tension, you do not go with that size. You need to go with the larger size tube. So you need to go with 24 to 28 French preferably, due to the risk of bronchopleural fistula with smaller tubes. So the main rationale for selection of the tube size is your Hagen-Poiseuille equation. So whereby they say the flow is directly proportional to the pressure and the fourth power of radius, and inversely proportional to the length and the viscosity. So what is relevant to us is the flow, the pressure, and the radius. So the larger the size of the tube, the better the flow. So there will be better let out of gases. So next common thing is many a times in ICU, usually following a pneumothorax, some people have a tendency to put a negative pressure suction. Is it really recommended? No. Routine use of negative pressure suctioning is not recommended. There is no evidence to suggest its benefit. Where do you use negative suction? Because in cases with pneumothorax where you put an ICD, where you've taken serial X-rays and you find that there is not adequate let out of gases or air from the pleural cavity, and you find that the tube is still in position within the pleura, then in those subset, you can try putting a negative suction to aid in assisted removal. So where do you put the ICD? So the placement is very, very crucial because you do not want to injure vital structures. So where do you do it is there is some place called the triangle of safety. So triangle of safety was asked as a question in the recent theory exam. So it is important to know about it. Please memorize it before your exams. So any pneumothorax is best treated with a chest tube placed in the fifth intercostal space, just anterior to the mid-axillary line. So the triangle of safety, the base is the fifth axillary line. Sorry, the face is at the fifth intercostal space. The anterior part is the lateral edge of the pectoralis major. The posterior is the lateral edge of the latissimus dorsi, and the apex is the base of the axilla. So I'll repeat it once more. The base is formed by the fifth intercostal space. The anterior part is by the lateral edge of the pex major. The posterior is by the lateral edge of the latissimus dorsi, and the apex is by the base of the axilla. So this is the triangle of safety, and this is the place where you need to place the intercostal tube. There is a thoracostomy tube, which is then connected to the intercostal drain. So the important thing is when patients present with chest pain with breathlessness, you need to always keep other differentials in mind. So one differential is pulmonary embolism, acute coronary syndrome, pneumonia, acute pericarditis, rib fractures, esophageal spasm, and acute costochondritis. So all these differentials need to be kept in mind, and each of them have different diagnostic modalities for information. So we have completed the first talk. So then I'll upload my next talk. Is the screen visible?
Yes, Shrihari.
Yes, sir.
Okay. Okay. So the next topic is about care of patients with thoracostomy tube drains. So the areas I will be covering is on the introduction, the indications, the chest drainage system, management, complications and troubleshooting, and removal of thoracostomy tubes. The problem with theory exams is there will always be 1 to 2 bouncer questions. Like in RESPI, they may ask questions related to chest physiotherapy or incentive spirometry, mobilization, rehabilitation. Those kind of questions have been asked in the recent years. So this is also another potential question that can be asked. So it is important that you know about it. So coming to the introduction, thoracostomy tubes placement belongs to one among the most performed procedures, whereby it can either be life-saving, as in tension pneumothorax, or aid in enhanced recovery, that is in post-surgical patients, or for symptomatic relief in malignancies. Despite many benefits of thoracostomy tube drainage, the potential for significant morbidity and mortality exists with thoracostomy tubes being in situ. Hence, regular assessment and troubleshooting of complications is crucial for ensuring improved outcomes. So, thoracostomy tubes placed in the hospitalized patients require daily assessment to determine one, the presence of air leak, provide ongoing adjustment of suction level, and monitor for malfunction, which may include obstruction, malposition, or disconnection. So, coming to the indications, one, to remove air collections in the pleural space, like in tension pneumothorax or a simple pneumothorax if the patient is on mechanical ventilation. Or to remove fluid collection in the pleural space, like in hemothorax, a malignant pleural effusion if symptomatic, chylothorax, a complicated parapneumonic effusion, or an empyema. Use as a delivery conduit to introduce medications or fluid into the pleural space, as in internal warming via installation of warm saline, or pleurodesis with talc can be instilled to promote scarring of visceral and parietal pleura, or hyperthermic intrathoracic chemotherapy in cases of malignant pleural, mesothelioma, and metastatic disease. So when it comes to the indications for thoracostomy tubes, it can be classified into these 3 subgroups. Just one more thing I just wanted to say, since I have not mentioned it. Since there will be discussions on acute and chronic liver failure, they will be talking about hepatic hydrothorax. The important thing to mention is in hepatic hydrothorax, there is no role of use of thoracostomy tubes. All right. So since we are talking about it, I just wanted to emphasize that also. So in hepatic hydrothorax, no thoracostomy tubes. So the next is about the chest drainage system. So you have the one bottle system, the two bottle system, and the three bottle system. So what are the main functions that you need to look into is one is the water seal, the drainage, and the suction. The water seal, drainage, and suction. So in the one bottle system, you have a water seal, and on the other side, along with it, you have a drainage also. All right. So water seal and drainage come together in a one bottle system. In a two bottle system, the water seal and drainage are in one bottle and the suction is in the other bottle. In a three bottle system, the first bottle is for drainage, the second is for water seal, and the third is for suction control. All right. So this one bottle, two bottle, and three bottle system is very important to be remembered. So one bottle is for water seal and drainage, two bottles for water seal and drainage as in one bottle, and the other one for suction control. And in three bottle, the first is for drainage, the second is for water seal, and the third is for suction control. So coming to the management, there are 5 important areas that we will look into. One is the precautions during initial drainage, monitoring of the patient, assessment, chest physio, and patient transport. So the precautions during the initial drainage. The amount of thoracostomy drainage should be assessed on a regular basis, ideally hourly in the setting of trauma. So with the traumatic hemothorax, in general, there are three important criteria to be looked into. One, if the initial drainage is more than 1500 ml, or if the initial drainage is more than 1/3 of the patient's blood volume in the thoracic cavity, or the rate of bleed is at 200 ml per hour for the first 2 to 4 hours. If any of these are present, then you need to have a high suspicion of an thoracic vascular injury and proceed for a emergency thoracotomy. All right. In cases of massive pleural effusion, the fluid should be drained slowly. There should not be more than 1 liter drained on the first go. If at all by mistake this has happened, you need to clamp it for an hour, then drain it at every 1 to 2 hours, about 300 ml at a time, with the tube being clamped in between. Why do you want to do this? This is mainly to prevent re-expansion pulmonary edema, because the patient would have been admitted with hypoxia, you would have identified a massive effusion, you would have proceeded for tapping, but in one shot, if you try to remove all the fluid, the patient is again going to go into severe hypoxia. Then the patient's FiO2 requirement is further going to go up. If the patient was not intubated, then there's a very, very high chance the patient may get intubated, and that will further increase morbidity. So you need to be very, very careful with the amount of fluid that is being drained in cases of massive effusions. There will be rare instances where there may be a large effusion with an active air leak. So when there is a large effusion, we told you will have to clamp it and release it slowly. But if there is also the presence of an air leak present, then you cannot clamp it because that is going to trigger a pneumothorax. So this is a very tricky situation. So to reduce the risk of re-expansion pulmonary edema in this subset of patients, what can be done? You can take a drainage tube and drape it from the insertion site to a level above the patient's head and then back to the drainage system, which is ideally on the floor. Now, what this does is basically is it creates a fluid trap that allows the air to escape freely but slows the drainage of fluid. So this is an important scenario that can be asked in the practical exam, and it was asked. So that is why I've put this slide specifically. So if the collection bottle gets filled with drain blood or fluid, it should be emptied after clamping the tube, and it should be done in a completely sterile manner. The drainage system must remain upright for the water seal chamber to function correctly, and the drainage system must be lower than the chest to facilitate drainage and prevent backflow. So monitoring of the patient, you will have to monitor the vitals. That is very, very important. That is the heart rate, BP, saturation, respiratory rate, and GCS. You need to assess for pain because with larger size thoracostomy tubes, it will keep impinging along the intercostal nerves. So that can cause a lot of pain with respiration. So whereas if it is pigtail catheters, usually the pain is relatively less because it does not cause that much impingement or impairment of your respiration. Then you need to always assess the insertion site, whether there is any soakage present or not, and also look at the dressing. Then you need to assess the respiratory parameters. You need to assess the chest wall movement and auscultate the chest to assess the intensity of breath sounds. And X-ray should be done to find out the exact position of the chest drain and evaluate the status of the underlying expansion. Now, what this second sentence means is you have a patient with a pneumothorax for whom you put an ICD. You will have to again reassess the X-ray to assess the degree of lung expansion that has occurred. Though you can use ultrasound for medical legal purposes and for academic purposes, X-rays also need to be done to assess the level of clear expansion. And also you need to assess for the presence of subcutaneous emphysema. Now, following thoracostomy tubes, can subcutaneous emphysema occur? Yes. How? There can be sometimes when there can be tube malposition, whereby there can be few holes that can be outside the pleural cavity. Outside, so that can cause leakage of air into the subcutaneous space and lead to subcutaneous emphysema. So it is very, very important to monitor for it. So assessment should be done at a minimum of every 15 minutes for the first hour following chest tube insertion. And any alteration in the patient's hemodynamic and respiratory mechanics should be monitored for and appropriate management. Because there may be times when you would have put an ICD, then after that you would have settled everything and gone. But the problem is you would have gone to see another patient. At that time, they would have positioned the patient and the staff very nicely would have clamped the ICD tube. Then you would see they would call you saying that the BP is very low. And when you go and assess, you would not have much clarity what is going on. So then you need to again look into the tube circuitry, whether how it is, whether there is any obstruction. And if it is there, it needs to be relieved at the earliest. So always looking at the patient's hemodynamic and respiratory mechanics must be monitored. So this is the image I was talking about. Once a pneumothorax had been relieved, the problem was the ICD clamp. ICD was clamped, and the doctor did not mention about it nor know about it initially. But the patient's BP had started to fall, so he was very concerned, and he just asked for a follow-up X-ray, and he found this finding. And later on, he realized that the thoracostomy tube was clamped. So it is always important to monitor for always obstruction or any malpositions. So coming to the assessment of draining. So always need to be monitored for tidalling. So what is tidalling? In local terms, it is your column movement. So when the fluid along the dependent portion of the tubing is seen to move back and forth with respiration, it is a sign that the tube is patent and it is moving by the flow of the diaphragm. So the absence of tidalling indicates that there is a tube occlusion. Or in a fully expanded lung, idling may not occur. Then you need to assess the integrity of the drainage system. That is, you need to assess the amount and character of the drain. Initially, there can be a lot of blood that would have come, that would have been collected blood. Subsequently, it becomes serosanguinous and then serous. During this phase, if at all it was initially serous and then again it starts to become bloody, then you need to be very concerned. Or if you start to notice there is evidence of pus coming out in the drain, you need to be all the more concerned. Then you need to assess if there is any tube being kinked or bent. It can interfere with the drainage. And always check the water levels in the water seal chamber. If it is inadequate, excess suction pressure can occur on the delicate pleura. And always make sure that the chest tubes are not clamped, which is very, very important. Then assessment for air leaks. So the presence of air leak should be assessed to determine whether the tube can be removed. So most intrathoracic air leaks will usually seal spontaneously and resolution can be tracked by witnessing decreased bubbling in the device over days. Bubbling within the chamber can be related to an air leak anywhere within the circuit. So how do you go about it? First, begin the evaluation at the chest tube insertion site to evaluate if there is any atmospheric air tracking into the thoracic space via the chest tube insertion site. That is the insertion site and the tube position. Then, next you clamp the tube near the patient end briefly to assess if the leak is downstream. If you find that there is leak in the downstream, then you need to replace that unit. If the first two are not there, then you need to assess for intrathoracic pathologies like bronchopleural fistula. So qualitative air leaks can be classified as follow with increasing severity. If it occurs only with forced expiration, that is Valsalva or coughing, it is supposed to be very mild. Then the next part of the severity is expiratory, during the expiratory phase, whereby there can be an alveolar pleural fistula, or if this leak is present during inspiration, whereby it is an alveolar pleural fistula or a bronchopleural fistula, or it occurs continuously, both during inspiration and expiration, whereby it is a true bronchopleural fistula, which could have occurred because of trauma hydrogenically, when you have pushed the ICD too much and it has caused a parenchymal injury. In those cases, you can develop a true bronchopleural fistula. So that is why when you do thoracostomy tube insertion, they always preferably say to go with forceps dissection and then push it inside because there is a relatively lesser risk. Whereas in emergency situations where you want to push it inside, you need to be very careful about the amount of force that you give it. Because if you give too much of force, that can itself traumatize the lung parenchyma. So you need to be very, very careful. So then coming to the level of suction. So the typical initial level of suction used in the clinical setting is about -10 to -30 centimeters of water. So when the thoracostomy tube or catheter is placed for fluid drainage, -20 centimeters of water is a reasonable place to start with. And the level of suction should be increased as indicated with the goal of achieving full lung expansion as determined by the chest radiograph. So for a collapsed lung due to pneumothorax or copious pleural effusion, large differential gradient should be avoided during re-expansion to prevent re-expansion pulmonary edema. So if suction is not ordered, ensure that the suction port is left to open. The next is chest physiotherapy. So patients should be encouraged to ambulate as soon as possible. Deep breathing and breath holding exercises should be initiated as soon as possible after chest tube insertion. So this facilitates effective lung expansion and drainage of fluid. Patient transport. During transportation, the chest tube bottle or bag should be kept lower than the chest level. It is important not to clamp the chest tube as continuous drainage is the safest option. In cases where there is an air leak from the lung surface, Clamping the tube will lead to accumulation of air in the pleural cavity, causing lung collapse and sometimes increasing the risk of developing a tension pneumothorax. So coming to the complications, if you have organ-specific complications like esophageal injury or gastric injury with use of trocas, bowel injury, hepatic, splenic, diaphragm injury, all these, if at all, you are putting the thoracostomy tube at a very low level, or they can, because of high pressure that is pushed into the lung, it can cause lung injury in the form of perforation, infarction, or a bronchopleural fistula. Especially with left-sided thoracostomy tube drains, there is an increased risk of cardiac or vascular injuries. There can be intercostal arterial hemorrhage or chylothorax, especially with left-sided tube insertions. So that all needs to be looked into. Then you have technical complications like non-functioning tubes being clogged or a dysfunctional closed system, subcutaneous placement, tube dislodgement or removal. Then physiological complications like re-expansion pulmonary edema or vagus nerve irritation, which is supposed to be very, very rare. And infectious complications. You can have insertion site infections with the most severe form manifesting as necrotizing fasciitis, or there can be empyema. During the COVID-19 era, especially during the second wave, where there were a lot of lung complications, severe lung complications, many patients developed pneumothoraces and many of them needed ICD. And the ICD needed to be kept for a long period of time because of a lot of leak that was present. And all these subset of patients, empyema was invariably present. So it is a very important complication that needs to be always looked into in patients who have an indwelling ICD for prolonged periods of time. So coming to the last part, that is removal of thoracostomy tubes. To minimize the risk of infectious complications, the tube should be removed as soon as it is safe to do so. So as I said, one of the dreaded complications is infections. So if the indication for a thoracostomy tube has been satisfied, then it needs to be removed at the earliest. So for a pneumothorax, the criteria are the lung should be fully expanded. There should not be any visible air leak present, and air should not accumulate when the suction is removed. If the patient is on mechanical ventilation, preferably the patient should be on pressure support mode of ventilation. For a pleural effusion, the criteria are little different. One, the lung is adequately expanded. The drain output should be less than 100 ml per day, and there should not be any fresh or altered blood or pus draining from the chest tube. So these are the criteria that you need to keep in mind before removal. So the removal technique, before removing the chest tube, the nurse assistant should be ready with the following. One is a dressing strip with sterile gauze pieces and artery forceps, sterile water impermeable adhesive wound dressing, and a tight adhesive dressing. So at the peak of deep inspiration, the chest tube should be pulled out gently. While one person pulls out the chest tube, the other person should be ready to tighten the purse string sutures to prevent any air entering the chest, especially with post-surgical drains. Then a water impermeable occlusive dressing is applied at the site of insertion, which is then removed after 48 hours. So post removal, always assess for respiratory distress, and you need to do a follow-up chest X-ray to look for pneumothorax or any other abnormalities. So this is about the second talk. So my last discussion is on high flow nasal cannula and the ROX index. Is the screen visible?
Yes, Shriyari.
Okay. So under HFNC and rocks, I'll be discussing mainly on the introduction, the components, the physiological effects, the indications, the rocks index, and HFNC associated trials. So your theory questions will be pertaining to any of these areas. So it is important to know about it, these. So HFNC has been gaining attention as an alternative means for non-invasive ventilation for critically ill patients, especially in whom NAV intolerance is a big concern. So what are the components of it? You have an air or O2 blender, you have an active heated humidifier, then you have a single heated circuit, and you have a nasal cannula. So HFNC will be able to deliver heated, that is about 32 to 37 degrees, and humidified up to 100% relative humidity oxygen with an FiO2 that can be varied between 21% and 100% at flow rates up to 60 liters per minute. And the FiO2 and flow can be titrated independently based on the patient's requirements. So as you can see here, this is a HFNC circuitry where this is a air and O2 blender. Then there is a heated humidifier, then the heated tubings and the nasal cannula. So physiological effects of HFNC, this is very, very important, very commonly asked theory question. So please concentrate on this. One, this is about the humidification of oxygen. Inhalation of cold and dry air usually leads to dryness of the airway. Why this is a concern is it will lead to impaired mucociliary functions, that is, impaired secretion clearance and airway defenses. And dry airway usually leads to increased airway resistance, and increased airway resistance is usually associated with an increased work of breathing. Now, how HFNC helps is it not only provides high flows, but also contains an active humidifier which warms and humidifies air before delivering to the airways. So this humidified air loosens the thick secretions and provides mucociliary functions, improves mucociliary function and improves airway clearance. So this is one of the ways where it is beneficial. That is humidification of oxygen, thereby improving mucociliary functions and improving airway clearance. Then second, reduction of the anatomical dead space and increased carbon dioxide washout. So before going in depth, anatomical dead space, what is it? It is the segments of the respiratory tract responsible for conducting air to the alveoli and respiratory bronchioles, which does not take part in the gas exchange. So continuous flow of fresh air at high flows produces a more efficient ventilation by facilitating carbon dioxide clearance from the anatomical dead space, thereby reducing minute ventilation and work of breathing. All right. Then control in the fraction of inspired oxygen. So the inspiratory flow of a patient varies with each breath. If the inspiratory flow is more than the supplemented oxygen flow, then the remaining air is recruited from the atmosphere. So that leads to dilution of the oxygen content with reduced FiO2 being delivered. I'll repeat it once more. If the inspiratory flow that the patient is taking is way higher than the supplemental O2 flow, that is with conventional O2 therapy, that is you are giving O2 via 6 liters or 7 liters, then the remaining air is recruited from the atmosphere. So that will lead to dilution of the oxygen content with reduced FiO2 being delivered. In this situation, HFNC helps by providing a high and constant flow and overcomes this issue of gas dilution. It is more constant at high flows and can be maintained between 0.21 and 1. The next benefit is generation of positive expiratory pressure and alveolar recruitment. The high flow through the HFNC can provide a small positive pressure in the airways. So with the mouth closed during breathing and a maximum flow of 60 liters per minute, the pharyngeal pressure remains around 3 centimeters of water. And along with this, the PEEP, which occurs because of this increased flow, causes shift of fluid in the alveolar space to the perivascular interstitial space, increasing the number of alveoli participating in ventilation. That is, it aids in alveolar recruitment. And the last is about patient comfort. So with the patient on HFNC, they will be able to talk and eat during HFNC, and they often prefer HFNC to other forms of non-invasive positive pressure ventilation like BiPAP or CPAP because they do not have tight-fitting masks which can be uncomfortable and cause claustrophobia. And compared to conventional oxygen therapy, it is better tolerated because of the warmed, humidified gases that do not dry the respiratory mucosa. And most patients are comfortable using it for prolonged duration of time. So these are the important physiological effects that need to be kept in mind. One is humidification of oxygen, improving mucociliary functions and airway clearance, reduction of anatomical dead space and increased carbon dioxide washout, reducing minute ventilation and walk-up breathing, control in the fraction of oxygen. Third is generation of positive airway pressure, which helps in keeping the pharyngeal, the upper airway open, and it aids in pushing or shifting fluid from the alveolar into the interstitial spaces, thereby increasing alveolar recruitment. So this is another diagrammatic representation. So here you can see the decreased inspiratory effort, increased comfort because of humidification, improved mucociliary clearance, decreased air entrainment, reduction in the respiratory rate because of the decrease in work-up breathing, increased airway pressure because of the PEEP effect, and increased carbon dioxide washout because of the decrease in the anatomical dead space. So this is another flow chart of what I had just told. Because of the high flows, it has effect on your expiration and inspiration. With respect to the expiration, it has a PEEP effect, which aids in alveolar recruitment, plus it aids in dead space washout. With respect to the inspiratory part, it increases the peak inspiratory flows. It compensates for the peak inspiratory flows. It is able to provide a constantly high FiO2, and it aids in alveolar recruitment and redistribution of tidal volume. So all this leads to improvement in gas exchange, which reduces the work of breathing. And humidification heating improves patient comfort and compliance. And they say that it has a role on reducing microatelectasis. So that itself helps in improving overall respiratory distress. So where do you use it? So as of now, the areas where it has been studied and shown to show a certain amount of benefit are in patients with hypoxic respiratory failure, in patients following extubation, in post-operative HFNC in high-risk and obese patients following cardiac or thoracic surgery, during the peri-intubation period. So these are 4 areas where it is being studied. And other areas where it can be used are in do not intubate situation during bronchoscopy or acute respiratory failure in immunocompromised patients. So the indications are in hypoxic respiratory failure, post-extubation status, or peri-intubation period, or post-operative in high-risk obese patients undergoing cardiac or thoracic surgery, and other scenarios like DNI during bronchoscopy or acute respiratory failure in immunosuppressed patients. So how does it, what are the rationale behind its use? So in acute hypoxic respiratory failure, this is based on the floral trial. There is similar rates of intubation compared with NAV and face mask, but it has been associated with the reduced ICU and 90-day mortality. And it has shown to improve breathlessness following treatment initiation. With respect to prevention of post-extubation respiratory failure in low-risk patients, HFNC was found to be superior to conventional O2. In high-risk cases, it was found to be non-inferior to NAV. For breaks from positive pressure ventilation, it permits oral intake and communication and it is more comfortable than conventional nasal cannula and NAV. The thing with nasal cannula is with higher O2 being delivered, it can cause dryness of your nasal air, nasal mucosa, and that itself can cause an increased risk of nasal bleeding. Oxygenation during airway procedures, pre-oxygenation prior to or during endotracheal intubation, it helps oxygenation during bronchoscopy compared to conventional nasal cannula. So these are the benefits and the rationale for use in these subset or indications. So monitoring of the patients on HFNC. So how you can monitor the patients on HFNC is by use of your ROX index. So the acronym ROX stands for respiratory rate and oxygenation, and it primarily reflects the work of breathing. So that is the main purpose of your ROX index. So it is defined as the ratio of your SpO2 and FiO2. That is S is to F is to respiratory rate. It was primarily used to predict HFNC failure in patients with acute respiratory failure, but it can be also used in non-invasive positive pressure ventilation patients, but with moderate accuracy. So the components are saturation of oxygen, FiO2, and the respiratory rate. So the interpretation. So once you put the patient on HFNC, you need to assess certain time points. At the time of initiation, you need to assess the rocks. Then at 2 hours, 6 hours, 12 hours, and more than 12 hours. So you need to assess the rock score. So the threshold for intubation is taken based on these numbers. At 2 hours, you check the ROX index and assess if it is 2.85. If it is less than this, don't worry. If it is more than that, you need to be concerned. There is an increased risk for intubation. So it has a positive predictive value of 99%. The same is still 12 hours. At 6 hours, it is 3.47, and at 12 hours, it is 3.85. So these numbers need to be memorized before the exam, because if at all ROX index is asked, the threshold for intubation based on ROX index, the numbers need to be known. So 2.85, 3.47, and 3.85. So these numbers will give you a good positive predictive value. But if it is more than 12 hours, the ROX index threshold is taken at 4.88. But if you see here, the positive predictive value comes down to 80%. All right. So these numbers need to be memorized, and the timeline when it needs to be done also needs to be noted. So if at all you find that the ROX index is more than these values, then the threshold for intubation should always be kept in mind. Another important thing I wanted to emphasize is just this is not pertaining to this. In patients on non-invasive ventilation, you have something called the Hacker score, which is also shown to have good sensitivity in identifying patients who are likely to fail NAV. So in HFNO patients, ROX index was found to be superior to the Hacker score. So it is a good score for assessing patients who are at risk of HFNC failure. But you also need to know the limitations. So limitation one is ROX index was developed and mainly studied and validated in patients with ARDS who presented with type 1 respiratory failure. So whether this can be contemplated and used in other subset of patients is still under study. There are a lot of studies going on to assess its efficacy in other subsets who present with hypoxia. A key feature is the accuracy of your ROX index. The important thing is you need to avoid hyperoxia, because excessive O2 can falsely lead to a low SF ratio, impairing your ROX index. So the important prerequisite is you do not increase your target saturation more than 94%. So you keep it at 94 or below 94 as your cutoff, and you accordingly assess the ROX index. So that is when you are going to get a good valid score. Another important limitation is the predicting the probability of intubation is not limited to respiratory parameters alone. Because if you see the Hacker score, it also looks into the GCS. So neurological and hemodynamic factors also play a role in assessing the patients who are at risk of going into ventilation, intubation, and mechanical ventilation. So these are the three important limitations that need to be known about. So as I said over here, the ROX index, if it is less at 2 hours, if it is less than 2.85, you intubate. 6 hours, 3.47, intubate. 12 hours, if it is 3.85, you intubate. So in all this, you need to take it very seriously because the positive predictive value is very, very high. Then you have something called the ROX HR, that is the ratio of the ROX index to the heart rate. So if it is more than 8, calculated at 6 and 10 hours after initiating HFNO, it was very much superior to ROX index in predicting HFNO success. All right. So the main important take home is, other than ROX index, you have something called the ROX HR index. That is the ratio of the ROX index to the heart rate. So that has been found to be superior to the ROX index in predicting HFNO success. And the score more than 8 calculated at 6 and 10 hours after initiating HFNO are the important things to look into. So HFNO associated trials. So one is the pre-oxyflow trial. So the clinical question was, does HFNC improve the efficacy of pre-oxygenation before intubation compared with a high fraction inspired O2 facial mask? So compared to high fraction O2 face mask, HFNO has a pre-oxygenation device did not reduce the lowest level of desaturation. All right. So it is a good tool that can be used during pre-oxygenation. Then you have the Florali trial. In that, the clinical question was, in patients with acute hypoxic respiratory failure, does HFNC compared with standard O2 deliver through a face mask or NAV prevent intubation? So in patients with acute hypoxic respiratory failure and without hypercapnia, treatment with HFNO did not result in a significant different intubation rates compared with face mask or NAV, but it was associated with a significant difference in favor of HFNC in reducing 90-day mortality. So this was a very important trial that showed the benefit of HFNC, the Florali trial. Then you have something called the OPERA trial. So in patients who have undergone major abdominal surgery, does application of HFNC compared with standard O2 therapy decrease the incidence of hypoxia at 1 hour after intubation? So among patients undergoing major abdominal surgery and receiving intraoperative lung protective ventilation, preventive application of HFNC after extubation compared with standard oxygen therapy did not result in statistical significant reduction in the incidence of postoperative hypoxia. So the main conclusion or take home in relation to this trial is, the routine use of postoperative HFNC after extubation does not seem to be justified in similar subset of patients. This was the recent trial that came out in 2024. That is HFNC versus NAV for acute exacerbations of COPD with acute moderate hypercapnic respiratory failure. This was a very important trial because they had shown that in ASCOPD patients with moderate hypercapnic failure, HFNC was not non-inferior to NAV and resulted in higher incidence of treatment failure than NAV when it was used as the initial respiratory support. So even till today, NAV is the standard modality of ventilation in patients who present with AECOPD. All right. So HFNC is not a good modality of ventilation in this subset of patients. Thank you. So if anyone has any queries, please put it up in the chat box or in the group. Be happy to clear them.
Thank you, Srihari.
Thank you, ma'am.
So good evening, all. So this week there will be a mixture of two topics. So simultaneously we'll be taking respiratory as well as endocrine. So I think two of three important topics has been discussed by Dr. Srihari. So now we'll go to the endocrine topic. The important one is SIADH. So the outline of the topic would be introduction. What is the etiology of SIADH, pathophysiology, the clinical features, evaluation, treatment, and what are the complications. Previously, in DRNB December 2022, the question that has been asked on this topic is difference between SIADH and cerebral salt wasting. Now, what is SIADH? Syndrome of inappropriate antidiuretic hormone release. So, it is a condition wherein there is an unsuppressed release of antidiuretic hormone either from the pituitary gland or from non-pituitary sources, or the continued action of this ADH on the vasopressin receptors. Okay, so the condition was first detected in lung cancer patients by William Schwartz and Frederick Barter in 1967. And this condition is mainly characterized by impaired water excretion. So what happens here is there will be water reabsorption leading to either hypervolemic or euvolemic hyponatremia. So coming to the causes. Okay, so SIADH could be due to hereditary causes or it could be due to some secondary causes. So hereditary SIADH is also known as nephrogenic SIADH, and this occurs due to some functional mutation in the vasopressin 2 receptors which are present on the kidneys. Okay, now for us the important one is the secondary SIADH. So secondary SIADH could be due to some CNS causes like stroke, any intracranial hemorrhage, infections, trauma to the brain, any mental illness or any psychosis. And in these cases, the cause of SIADH is due to increased release of ADH from the pituitary gland. The second important cause is the malignancies. Okay, so the most common malignancy which is associated with SIADH is the small cell lung carcinoma. The other malignancies could be extrapulmonary small cell carcinoma, head and neck cancers, and olfactory neuroblastomas. And in these cases, the cause of SIADH is due to ectopic ADH release from the tumor cells. Third would be some drugs which may cause SIADH. The commonest include carbamazepine, oxcarbamazepine, chlorpropamide, cyclophosphamide, and SSRIs. And these drugs may lead to increased release of ADH, or it is due to increased effect of ADH on the cells or on the receptors. Certain surgical procedures are also associated with hypersecretion of ADH due to a response which is mediated by pain afferents. Some pulmonary diseases like pneumonia, ARDS, atelectasis, pneumothorax may also rarely cause SIADH, and the mechanism in these cases is unknown. Hormone deficiencies like hypopituitarism and hypothyroidism may be accompanied by SIADH or may lead to SIADH. And some hormone administration, like we administer vasopressin to control the upper GI bleed, desmopressin to treat von Willebrand's disease, hemophilia, or any platelet dysfunction, and oxytocin to induce labor. All these may increase the activity of the V2 receptors and may lead to SAIDH. So these are the secondary causes of SAIDH. So if we finish the definition, we finish the causes. Okay, causes could be hereditary or secondary. Now coming to the pathophysiology. Okay, we all know that ADH, antidiuretic hormone, also known as arginine vasopressin, is basically synthesized in the hypothalamus and then it is stored in the posterior pituitary. Okay, so what is the main function of this ADH? So it maintains the plasma tonicity, which is known as osmoregulation. Now, how is this plasma tonicity maintained? It is maintained by three important things. One is the sodium, one is the glucose, and the other one is the urea. So while calculating the serum osmolality, we use all these three. But the main component is the sodium. Okay, that is known as effective osmol because it is not freely permeable across the cell membrane. So it remains in the ECF and causes most of the or maintains most of the tonicity of the plasma that is required. Okay, the glucose and urea are known as ineffective osmoles, and while calculation we can even neglect the values of glucose and urea. Now these osmoreceptors, which are present at various in the plasma or in the various organs, they detect the change in the effective plasma osmolality in the hypothalamus. So normally, if there is a decrease in tonicity, okay, decrease in tonicity means if the patient is, example, if the patient is fluid overloaded, okay, so there will be decrease in tonicity. At that situation, the hypothalamus will send a signal to the posterior pituitary to prevent the ADH release. So when the ADH is not released, so what happens? It prevents water retention and leads to free water diuresis. But if there is an increase in tonicity, as seen in a hypovolemic state, okay, the pituitary, posterior pituitary releases the ADH, which basically acts on the V2 receptors, which are present on the cortical as well as the medullary collecting tubular cells. So these V2 receptors get stimulated and lead to the formation of some unique channels known as aquaporin to water channels. And what does these water channels do? They lead to water resorption. So what is water resorption? Water is absorbed down the concentration gradient. That is known as water resorption. Okay, so this is the same thing which happens in case of SAIDH. So now this is the pathophysiology. This is the normal physiology that occurs. Now what happens here? As I told, in SAIDH, there is increased levels of ADH due to either the secondary, a lot of secondary causes have been mentioned. So because of which there is increased levels of ADH, which leads to water resorption. Now what does this water resorption do? It does three important things. First, on the urine. So when the water is reabsorbed, okay, what happens to the urine? The urine volume is decreased, the urine osmolality is increased, and the urinary sodium excretion is increased. The opposite happens in the blood or the serum. So what happens in the blood? The blood volume is increased. There is increased serum hypoosmolality. So serum osmolality is reduced, leading to dilutional hyponatremia. And this water resorption, okay, also leads to decreased aldosterone release as a negative feedback. Okay, so these are the effects which is seen in SAIDH. Now coming to the clinical features. The clinical features of SIDH are due to two important things. One is the hyponatremia, the dilution hyponatremia which is seen. Secondly, there is hypoosmolality. Okay, this might lead to the movement of water into the cells causing edema of the cells, especially in the brain cells. So one is hyponatremia, second it causes cerebral edema. And the signs and symptoms, they also depend upon the rate and severity of the hyponatremia and also the degree of cerebral edema. So, clinical features of hyponatremia. So, they can be classified as mild, moderate, and severe hyponatremia. Mild is serum concentration of sodium between 130 to 130 to 134. Moderate is 125 to 129, and less than 120, it is known as severe hyponatremia. So in cases of mild hyponatremia, the clinical features could be most of the patients could be asymptomatic, but some patients might even experience some mild headache, nausea, vomiting, fatigue, some confusion, and the muscle cramps. For moderate hyponatremia, there could be gait disturbances, there could be severe headache and vomiting, confusion, and important thing is there is depressed deep tendon reflexes. And in severe hyponatremia, patient might experience delirium, seizures, respiratory arrest, brainstem herniation, coma, and even death. Okay, so these are the clinical features of hyponatremia. Now coming to the evaluation. So as I told, in evaluation, history is very important because we need to know what is the etiology behind this SADH. So see if the patient has a history of head injury, chronic pain, smoking history, any weight loss or pulmonary symptoms, any drug intake or substance abuse. And physical examination is mainly to determine what is the volume status of the patient, whether he is euvolemic or hypervolemic, because those two things suggest it could be secondary to the SIDH. And you should do a detailed neurological as well as the respiratory system examinations. Now, the important diagnostic criteria which is used for SIDH is the Schwartz and Barter clinical criterion, which was given by those who have discovered the SIDH. It was given in 1967. So, according to them, to tell SIDH, the serum sodium should be less than 135. Osmolality will be low, so it should be less than 275. What happens to the urine sodium and urine osmolality? It will be high. So urine sodium should be greater than 40 and urine osmolality should be greater than 100. And important thing is there should be absence of clinical evidence of volume depletion. Because if there is evidence of hypovolemia, it might suggest cerebral salt wasting. So we should see whether the what is the patient's volume status. And the other thing is the absence of other causes of hyponatremia should also be ruled out. And the important thing is when you do fluid restriction, there should be improvement in the serum sodium levels. That is correction of hyponatremia by fluid restriction. If all these criteria are met, then you can diagnose that this patient is having SIADH. Okay. Additionally, we also have to rule out the causes of pseudo-hyponatremia like hyperglycemia and uremia. Okay. So labs will be the same. Serum osmolality, serum sodium, urine sodium and urine osmolality. Do the renal function tests, blood sugars to rule out pseudo-hyponatremia, thyroid profile, cortisol, fasting lipid profile, liver functions, and patients with long-standing smoking history, weight loss, pulmonary symptoms. Important thing is we have to rule out the malignancies. So you have to do a chest X-ray and in some cases even the CT thorax. So now coming to the treatment part. So important things or what are the goals of the treatment in SIDH is first, you should correct and maintain the proper sodium levels. Second, you have to correct the underlying cause or the underlying abnormality which is causing the SIDH. Okay. So now in cases of mild to moderate symptoms of hyponatremia, the mainstay of treatment would be fluid restriction. Okay, so you have to restrict the oral water intake and the goal of restriction is between 800 ml to 1000 ml per day. So even with fluid restriction, if there is persistent hyponatremia, then you start giving the sodium chloride from outside. That is either in the form of oral tablets, salt tablets, or in the form of intravenous saline, normal saline. Okay, this is in cases of mild to moderate symptoms. Okay, and in those patients who have a hypervolemic state or whose urine osmolality is greater than 500, in such cases, a small dose of loop diuretics can be tried along with the above treatment. Okay, this is in case of mild to moderate symptoms. Suppose if there are severe symptoms like seizures, confusion, or delirium, along with water restriction, you have to give hypertonic saline. So hypertonic saline can be given either in the bolus form or the infusion form. So here, uh, most of the articles recommend to be given in a bolus form. So how do you give 3% saline here? So 100 ml bolus has to be given over 3 to 4 hours. And after giving the 3% NaCl, measure the values in around 4 hours. And if there is any improvement clinically, then you can stop it. Otherwise, you can try one more bolus dose. Okay. Now, what should be the values of sodium that has to be improved after 3 to 4 hours? It is 3 to 4 milli equivalent within the first few hours after correction. So, after the first dose, you measure the sodium and it should be improved by 3 to 4 milli equivalents. And as I told, if the patient's mental status does not improve, then you can try with one more 100 ml bolus of the hypertonic saline. So if you're worried if to give a recurrent boluses, then you can start a infusion also. Okay. So mild to moderate symptoms, fluid restriction is more than enough. If the patient has a persistent hyponatremia, then give either the salt tablets or your normal saline. If there are severe symptoms, fluid restriction plus your 3% NaCl. Okay. Now, is there a role of some second line therapies in SIDH? Yes, and we should know when to give these therapies. Okay. So, what are the indications? One is if there is persistent SIDH despite your fluid restriction. Second, important, it should be non-severe symptoms, which means that patient should have mild to moderate hyponatremia. So the sodium levels should be more than 125 and you have to rule out other causes of hyponatremia. Please remember it is mild to moderate cases only, non-severe symptoms. So in that case, if despite fluid restriction, despite your salt tablet or your normal saline which you have given, still there is persistent hyponatremia, then only you're going to use the second line therapies. If the patient has severe symptoms, please don't use this medications. So what are the second line therapies which can be used? The first one is tolvaptan. The second is the urea. The third one is the SGLT2 inhibitors. Okay. So we'll just go through the mechanism of action of these. I think most of you all know the mechanisms, just a small. So important thing is first, we have just seen what happens in SIDH. Okay, so there will be water resorption leading to so many effects. So what happens on the composition of urine? So there is free water diuresis and the urine sodium is also on the higher side. So sodium is excreted into the urine, and what happens to the plasma sodium? There is dilutional hyponatremia. So this mechanism we have already seen in SIDH. So what does tolvaptan do? How does it treat the, it is used as a treatment in case of SIADH. So what is tolvaptan? Tolvaptan is basically arginine vasopressin V2 receptor blocker. Okay. So it blocks the AVP V2 receptors, leading to reduced water resorption. Okay, especially in the collecting duct, leading to increased free water diuresis. Okay. So because a lot of free water is has come out in the urine, automatically it will increase the plasma sodium levels. Okay. So it doesn't have any effect on the sodium in the nephron. It just causes free water diuresis. That's it. Okay. This is the mechanism of action of tolvaptan. Now coming to the urea, we all know that urea is a osmotic diuretic. So it usually acts on the descending limb and in the collecting duct. And as we know, it is an osmotic diuretic. So it increases the free water diuresis, and with that, even the sodium is also excreted in the urine, leading to increased plasma sodium concentration. Okay. And the important one is the recent one which we are using is the SGLT2 inhibitors. So what is this SGLT2 inhibitors? Where does it act? It acts in the PCT of the nephron. And where it is exactly, what does it do in the PCT? It basically acts at the sodium glucose co-transporter. Okay, so when it acts on this sodium glucose co-transporter, it inhibits it. So it leads to, first important thing, it leads to glycosuria. This is how it acts even in cases of diabetics. So when the glucose is excreted, okay, along with the glucose, this glucose will even carry the water. So free water diuresis happens and the sodium also gets excreted, leading to increased in plasma sodium concentration. So this is how all these drugs are used in SAADH. So tolvaptan, urea and SGLT2 inhibitors. Now the other important thing is the rate of correction. Okay, so how much do you correct in the 24 hours is very important, the sodium. So all the guidelines suggest that not more than 8 milliequivalents of sodium should be corrected in 24 hours. Or in other words, it is 0.5 to 1 milliequivalent per hour. Not more than this you need to correct in uh, while doing any corrections for hyponatremia, because any rapid corrections may result in osmotic demyelination, leading to quadriparesis. So these are the two expert opinions or the guidelines. So in cases of general hyponatremia, the US expert opinion suggests that the target is between 4 to 8 millimoles per 24 hours, and the limit, the maximum limit you can go is 10 to 12 millimoles. But in patients who has hyponatremia with the risk factors for osmotic demyelination, example, risk factors means if the patient is alcoholic, if the patient is having liver disease, pregnancy, severe sepsis, in all these cases, the target should be little less, okay, like 4 to 6 millimoles per liter in 24 hours, and the limit is between 6 to 8. Whereas the European guidelines suggest that in general hyponatremia, the target should be 5 and the maximum limit should be 10 in the first 24 hours and 8 in the next subsequent days. Okay. And for hyponatremia with patients with high risk factors for ODS, it is same as that of the US opinion. So this is the rate of correction. Now, how to give 3% NaCl, what is the correction factors, what is the deficit, everything will be discussed in the hyponatremia chapter. Now, this is a simple way of telling your treatment. Okay. So, you have diagnosed the patient as SAIDH. The first thing you do is the fluid restriction. Okay. As I told, for initial fluid restriction should be between 800 to 1000. If it is not, you can still go up to 500 to 750 ml of restriction. Okay. With the fluid restriction also, if there is persistent hyponatremia, then you can try your second line therapies only if the patient has mild to moderate symptoms. So as I told, you can use 3 drugs, tolvaptan, urea and SGLT2 inhibitors. Tolvaptan, the initial dose can be started as 7.5 mg, and when you give tolvaptan, you can allow free fluid intake, means there is no requirement of fluid restriction. Okay. But when you give urea, which can be given as an initial dose of around 30 gram daily, you need to continue your fluid restriction. In SGLT2 inhibitors, the most studied drug is the empagliflozin, which can be started with a dose of 25 mg OD. And this can be done with or without a fluid restriction. Okay, so after that, you monitor your sodium, and yes, you are reaching your proper target. Then you continue until the sodium normalization happens. If the correction is too fast, then you have to cease the active treatment and try to give some intravenous hypotonic fluid plus or minus your desmopressin. But desmopressin has no action if you're giving tolvaptan, because in tolvaptan already the V2 receptor blockade is there. So if you give desmopressin, there is no effect for the reversal of the tolvaptan. So if there is too slow or if there is further decline in your sodium levels, then try to increase the doses of these drugs. Okay, and rule out any other causes for the hyponatremia. Okay, so this is how you treat your SAIDH. So as I told, complications are usually secondary to the hyponatremia which is present depending upon the severity. There could be headaches, memory problems, depression, tremors, muscle cramps, and in a severe form, it might lead to respiratory failure, seizures, hallucinations, coma, and death. And one more important thing is they'll ask about the difference between the SIDH and cerebral salt wasting. So you need to put it in the box form and just write it like this. So most of it, remains the same. So except the four things which I have just highlighted here. So what happens to the extracellular fluid volume in SIDH? So your volume status will be either euvolumic or hypervolumic, whereas in cerebral salt wasting, the patients are hypovolemic. If you come to the urinary sodium levels, both are more than 40. Serum uric acid levels are low in both of the cases. Fractional excretion of urate is high in both the cases. But when you come to the fractional excretion of urate after correction, okay, so after correction is fluid restriction or by any other means, it will be normal. It is normalized in case of SIDH, whereas it will be still high in case of CSW. This is one of the points to differentiate between the two. So as I told, urine osmolality in both the cases will be high and serum osmolality will be low. So when you do bun to creatinine ratio, so bun is basically, the bun will increase secondary to your dehydration. So bun to creatinine level, if you see, it will be high in case of CSW because there is hypovolemia, whereas it will be low to normal in case of SAIDH. And when you measure your brain natriuretic peptide levels, it will be normal in case of SAIDH, whereas it will be high in case of CSW. And the treatment for SAIDH, it is water restriction, whereas in cerebral salt wasting, since the patient is hypovolemic, you have to hydrate these patients, and in some cases, even a mineralocorticoid, like a fludrocort, has to be given. Okay, so this is the difference between SAIDH and the cerebral salt wasting. So this is one of the simple slide which gives everything about the hyponatremia and especially about the SADH. Okay. So whatever I explained, it is just in a simple form that has been given. And if it is a chronic SADH, please don't do any fluid restrictions, not treat it with any medications. So if the patient is symptomatic only, then you try something. Otherwise, need not to treat the chronic SADH. Okay. Thank you. So tomorrow at the same time, 5 o'clock, we will be doing 2 to 3 more topics of pulmonary, and I'll be doing a topic on thyroid storm tomorrow. Okay. So if any doubts, please let us know. Okay. Thank you all. See you tomorrow.